Thank you very much, Carol, for that lovely introduction, and to the Foundation for asking me to talk to you today. So I'm relatively new to the Garvan. I've worked on many different types of cancers and many different scenarios, from mice, fruit flies, cells, all the way through to humans in my career. But as Marie mentioned, one of the opportunities that I think is up for the taking here at the Garvan and the Kinghorn is to try and use the power of genomics to address some of the chronic long-standing problems we have in lung cancer and breast cancer, which is another area that I'm interested in. But today I'm going to talk to you about lung cancer and what we're doing here at the Garvan to try and address this terrible disease. So this is probably something that many of you don't know, but in terms of deaths caused by cancer, lung cancer is by far and away in Australia the #1 cause of cancer death. So it's not the commonest cancer, it's the second or third commonest typically, but it dwarfs all the other cancers. And there's some very important and nasty and very high profile cancers in this list here that attract a lot of funding. Lung cancer doesn't attract a lot of funding, and that's historically because people think that it's a smoking related disease, and if you smoke, therefore it's your fault and we don't really care about you. And when I was a young respiratory physician in Western Australia, and we used to do bronchoscopy lists, which is where we look down the airway looking for tumours, I used to think that everyone in Western Australia died from lung cancer because it was just case after case after case after case. Okay, so whether or not you've smoked really shouldn't matter. This is a really big problem. It's a public health problem, but it's also a scientific and clinical problem. Okay, so this is the typical journey of a lung cancer patient, from diagnosis to 5 years following diagnosis. Okay, so 9,000 new cases per annum in Australia. Only 20% of these patients will be curable or suitable for surgery. Okay, at 5 years, 10% are dead, 10% alive. So 50% of the patients who have an operation are still alive at 5 years, the other half are dead. 80% of the patients with lung cancer present at the stage where it's inoperable. Okay, 20% it's confined to the chest, and we treat these patients with chemotherapy and radiotherapy, so aggressive treatment with the hope that we can cure them. And about 5% are still alive at 5 years, 15% are dead at 5 years. And then there's the commonest group, that is patients who present when the tumour is widely spread throughout the body from day one. And we treat those patients with chemotherapy, a new type of treatment called targeted therapy that I'm going to speak to you about in a moment. And sadly, the only other thing we can offer these patients is supportive care and palliative care. Okay, and 55% dead at 5 years. So this is a disease that claims a large number of patients, and the case fatality rate, that is the number of patients who are diagnosed who go on to die from this in 5 years, is still around 90%. Okay, so we're not doing very well with lung cancer. This is the other really interesting thing that I'm quite interested about, and I'm hoping that the genomics will help us figure this out. So right now in the clinic, when I go to the clinic, a majority of patients are former smokers. Okay, so people of our age and older know that back in the old days, smoking was not considered to be a bad thing. It was actually recommended by doctors, it was recommended in the military, it was part of the culture of our society and was not frowned upon. And large numbers of these people have given up and done the right thing, but unfortunately they still carry a lifelong risk of lung cancer. It drops every year after you quit, but it never goes to zero. So a lot of patients have done the right thing and they've quit and given up, and unfortunately they're still going to go on to get this disease. There's an increasing incidence of lung cancer in never smoking women. This is women typically under the age of 50 who've never smoked. It's probably a new form of cancer that we haven't really seen before in our society until the last 10 or 15 years. And it's a very alarming development. We really don't know why this is happening. And also, as smoking rates decline, and of course in Australia we have very low rates of smoking in the adult population, other causes that have been drowned out by smoking over the years are going to become very, very important. And I think we're going to start finding that occupations a phenomenon called indoor radon, where certain parts of the world in the ground releases radon gas, and that causes lung cancer. The environment, chemicals and pollution are probably going to be important. People exposed to radiation, or even people treated with radiotherapy for breast cancer, for example, there may be a slight risk of lung cancer. Secondhand smoke is a big problem that we don't understand, and we haven't been able to measure accurately what the risk is. And there are rare cases of where lung cancer runs in families of never smokers. So the tip of the iceberg really, this is what's floating underneath that we don't really know and we can't measure at the moment. But as smoking disappears from our society, these causes will become more evident, I think, because it's up until really the last 20 years, smoking has been such a pervasive cause of lung cancer that we haven't been able to figure it out. Okay, so there's hope on the horizon. So about 10 years ago, a subgroup of lung cancers, about 5 to 10% of all cases, were found to have a mutation in their genome. So this is not something that the patient's inherited, this is something that the tumour has generated itself in its own DNA. Have a mutation in the genome that activates a growth signal that can be blocked by a new family of drugs called targeted therapies. And it turns out that one of the most effective targeted therapies is in lung cancer. So for years and years and years, no one wanted to work on lung cancer because nothing worked. And all of a sudden, this was one of the big interests that people had because there was a drug that worked. Now, it only works in about 10% of cases, but here's a patient with one of the mutations in their tumour, here's a big tumour, and after 6 weeks of therapy, the tumour's completely disappeared. Okay, now I have to tell you that this is not the common scenario, but this illustrates that if we understand more, we can actually potentially do something for all of these patients. The problem, though, is that the tumours are very clever. So they generate new mutations in their genomes that gets around this therapy, and they come back. And eventually these patients will all die of their lung cancer. Okay, so this is a breakthrough, but it's not a cure. Okay, it delays death rather than prevents it. The other big news is the immune system. Now this treatment is very early days, but there's some very exciting results coming out, particularly from Johns Hopkins, where I used to work. Okay, so it turns out that cancer cells have lots of damage to their DNA, and particularly smoking, paradoxically, causes lots of damage to the DNA. And that makes the tumour generate proteins that are abnormal in their shape because they come from mutated genes. And those are recognised by the immune system, okay, because the proteins that are coming out of the surface of these tumours are not self, they're new, okay, because they're from mutated genes. And so we now know that the immune system recognises these proteins and thinks that the tumour is a foreign agent or an infection. But the tumour makes things that stop the immune system from working. And these new drugs wake the immune system up from its sort of slumber induced by the tumour, and suddenly the T cells, the lymphocytes in the tumour cell, in the patient, suddenly recognise the tumour cells and gobble them up and have an effect. Now, this treatment is in its very early days, and it was pioneered in melanoma, which is where tumour immunology really began. But we think that this is going to be a significant benefit to lung cancer patients. But because the immune response is driven by mutations in the tumour, we need genomic technology to help us figure this out as to which patients will benefit. So there's definitely light at the end of the tunnel here. Okay, so one of the big problems we have in lung cancer is tissue. Okay, so to do cancer research, we need samples from people. And in the 20% of patients who get surgery, and I've put a cartoon in here rather than a real photo because it's morning tea, but we do a little, I'm not a surgeon, by the way, the surgeons do this for us. We put a little telescope into the chest, here are the ribs, with a little pair of, it's just like a robot surgery, and we snip out the tumour with a little zipper, okay? So this is a really great way to get lung tumours out without doing too much damage to the patient. But remember, this is only 20% of the cases. 90% of the research is done on surgical material, all right? Because obviously if you can cut it out, you can study it. The problem is the other 80% of patients, this is what we get. So this is someone holding a little vial, and that's the miserable little piece of lung cancer biopsy tissue you get from a patient. And all of that has to go to making the diagnosis. So for people like me who like to grow tumour cells in the lab, make them grow in mice, all that kind of stuff, this is really frustrating because you can do basically nothing with that. Okay, so we're actually not studying the 80% of the disease. We're actually only really studying the patients who are lucky enough to have surgery. And so after I finish, I'm going to go back to theatre and assist with one of these procedures. And this is where I think the game is really going to change. And this is a thing called endobronchial ultrasound transbronchial needle aspiration, or EBUS-TBNA for short. Okay, sorry about that. Okay, so this is a telescope type thing. Okay, so this is a CAT scan of a patient with lung cancer. And you can see this is the primary tumour here. And the tumour's already spread to a lymph node on this side of the chest and a lymph node on the opposite side of the chest. So this is inoperable lung cancer. So what we do is we use an endoscope to put down the patient's throat, where they're asleep, into the airways with a little light on the end of it so we can go into the lungs and look for things. The problem is that most of these tumours we can't see in the airway. They're outside of the airway. So the technology is really very clever. So on the end of the telescope, we put a little balloon, and there's an ultrasound probe. So just like an obstetric ultrasound you would have if you were pregnant, but it's plugged onto the end of this telescope. So here's the telescope in the airway of the patient. You shine the ultrasound through the airway, and you can see the tumour behind the airway. Okay? So here's the tumour here. This is a blood vessel. We don't want to put needles in blood vessels, so we stay away from those. And the needle's in the tumour, and when we aspirate these cells, we get thousands of live tumour cells, more than enough to play with in the lab for forever. Okay? So this is used for diagnosis. Okay? This came in Australia in about the last 10 years. And I've been passionately advocating that this is a big opportunity for research, because suddenly we can get our hands on live tumour cells from patients with advanced lung cancer, and these are the patients who really need to help. And what are we doing with those cells? Well, these are the bar fridges that Marie mentioned earlier. So this is the X10 Illumina sequencing technology, which many of you would have heard about, that allows us to do whole genome mapping in 2 weeks for $1,200. And what I'm hoping we can do, in fact, when we've already started this project in the last 12 months, is to study the genomic makeup of these cells, which are in patients with advanced lung cancer who are not going to get surgery. And the project we've started on is we're looking at the genome of this primary tumour, where the tumour started, and the genome of the tumour that's spread within the chest. And we found that they're dramatically different. So the tumour evolves one cell has left this tumour a long time ago and landed in this lymph node on the other side of the chest. And our data shows that it's undergone a completely separate course of evolution. So you're actually treating 3 tumours, not 1. Okay, so these things are branching off and evolving like bacteria develop resistance to antibiotics. Okay, we've got to get our head around this if we're going to make any difference to these patients and figure out how to better treat them. And the first thing to do is to try and understand how that's even possible and what we can do to stop it. So that's the end of my presentation, and I'll be happy to take any questions. Thank you very much.